Hey everybody, it's Sean Gibbons from the Communications Network. Hope you're doing well, you're healthy and all that. You are probably here because you were here for a virtual Communications Network virtual roundtable with Dr. Richard Wenzel. We're gonna get that underway in just a quick second. But as you're entering the room, and I see folks starting to come in, why don't you, if you would, take your finger or your mouse or whatever you're using to manipulate your computer, go down to the chat. Make sure you're talking to all panelists and attendees and just say hello. We've been doing this two-word check-in that we borrowed from Professor Brene Brown down at the University of Houston. So just how are you doing? Today, I'm gonna say, hey, it's Sean. And we're listening to a little Dr. John. As we get ready here. Two words. I'm gonna say congested and happy. It's got a little bit of spring allergies. But as you're entering the room, go ahead and type your name, where you're from, and that two-word check-in. Abby, how are you? Up in sunny Toronto, and how are you doing up there, Abby? Two words. Jay in San Diego, my friend, how are you? Grateful and happy. Good way to be. Kim, up in New Hampshire, lovely to have you with us. Thank you for being here. How you doing? Rebecca, enjoying a new puppy. Well, you're winning. That's great. Catherine in Toronto. Let's see. M in Chicago, or Mark in Chicago. Awake and curious. Great. Cindy, how you doing? Hot and sunny in Florida. Yeah, I'll bet. Hey, Derek, how are you? Over in Chevy Chase, just across the way. And we're all jealous of you, Rebecca. You got to tell us what the puppy's name is. Colin, you're down in Austin. How are you doing? Healthy and happy. Wish I was down there with you. I was just watching amazing. If y'all want to, I think this is on Netflix. There's a wonderful documentary about the story of Austin City Limits. So check that out if you can. Suzanne, how are you in Santa Cruz? Beaches are closed. Yeah, but for good reason, Suzanne. I promise they'll be back soon. Ocean's not going anywhere. Puppy's name is Welby. Oh, like Marcus Welby, MD, the old. That's great. Liz, how are you? Healthy in here. Great. Bill, how are you? Impending birthday. Hopefully it's a good birthday, Bill. They're all good. Grateful to have them. All right, Tally, why don't you continue saying hello and welcome to one another. We're listening to a little Dr. John. Song here is called Everybody Wants to Get Rich. But the chorus to it is, everyone wants to get rich and wealthy, but I'd rather be poor and healthy. So it's a fun little song. If you know Dr. John or Mac Robanak, if I'm pronouncing his name properly. Wonderful, wonderful number from back in the 70s. All right, so with that, yeah, Abby, it is. It's a great song. Check it out. You can probably find it on Spotify. I'll see if I can toss it into the chat. So we're about to get underway. Our colleague Carrie Klein's going to take good notes for us. Yabby Ferris is manning Twitter for us. We're taking notes there as well. If you want to follow along on two screens, Bill, I know you sometimes do that. Hashtag, you know it, is ComNetLive. It's COMNETLIVE. And I'm going to yak at you just a couple quick pieces of housekeeping before we run into it. Bill, how are you? Welcome from Charlotte. We've got a lot of friends down there. Tristan Mahabir is running the deck for us. Mr. T, if you would take him, Betsy, you saw Dr. John. I never got to see him. I would have killed to have done that. That would have been wonderful. I bet you he was great. Tristan, if you'll take us to the next one. ComNetwork Local. Y'all hopefully know what these are. Most of the cities y'all were mentioning, we have ComNetwork Local groups there. Idea is pretty simple. We bring people together based on kind of your shared culture, or your shared area code or zip code, and we connect people who do communications for good in your backyard. So the idea is, you live in Washington, D.C., maybe you're working at Pew Charitable Trust, maybe you'd like to know some people working over at Brookings Institution who do comms. We bring you together, and we do that now in 17 different cities. I think the DC group's gathering tomorrow, and I feel like Chicago, if I got that right, was gathering later today, if I'm not mistaken. Anyway, I'm quite sure that Carrie will put the link into the chat. So if you're interested in exploring whether there's a local group active where you are, welcome to do that. It's free and everyone's welcome. Just trying to help everybody build community with other folks who do similar kinds of work. Alexandra, if I'm pronouncing that properly, up in Iowa City, welcome. And northern neck of Virginia, Kendall, my old stomping grounds. I grew up just outside of Mount Vernon, Virginia. All right, Mr. Chief, you take us to the next slide. Circles, this is the other thing. If you were among the couple hundred folks who raised their hand, wanted to learn more about this last fall, were interested in participating, you already got this email. For the rest of us, I think it's either going out today or tomorrow. We're going to be sharing out a note inviting you to participate in these things called circles. The idea is pretty simple. We're going to gather you based on either the issue that you're working on or the job that you hold. So the idea is maybe we got a whole bunch of people working on ocean conservation around the country or around the globe. We're going to bring you together virtually, as we've all been doing lately, to build a community of practice for people who do communications work focused on ocean conservation or social justice, or the job you do. Maybe you lead a department, or maybe your job is digital strategy. We'll put you in touch intentionally and regularly gather you with those folks who can share ideas and information. Mohammed, how are you? You're up in Iowa too. Okay, lots of folks from Iowa. The other day we had a lot of folks coming in from New Mexico. And I think we have a bunch of Brazilians with us as well. So say hello if you can. We're hopefully you all are healthy and well down there. And with that, I'm going to go ahead and hand it off to Dr. Wenzel. This is the 6th time he's been with us. So if you've been with us before, you know what a wonderful gift and treasure this is. If not, brace yourselves, buckle up. We are in for a really, really wonderful session. We're going to learn a lot. Obviously, no one in the world knew what COVID-19 was last November. We're all learning each and every day. And Dr. Wenzel is studying this and is going to share with us what he's been learning and what we should all be expecting in the coming days and weeks. And Lishka, nice to see you from Petaluma. How are you, Dr. Wenzel? Sir, take it away. And I'll see you all.
Sean, thanks very much. And show this cover slide just to remind me to say thank you for everyone on the webinar. If there are questions that are only partly or never answered, my email is here listed. And lastly, I will name drugs or vaccines and want to assure you I have no conflict of interest. I have no equity in any pharmaceutical product or medical product at all. So could I have the next slide? So I show you this slide with the painting on the left called Separation by Edvard Munch, the Norwegian expressionist who was also the composer for The Scream. And what you see in this painting is the woman with flowing light hair looking away from her lover out at the sea. Her hair barely connects on to his, and the man in black, the symbol of sorrow and despair, clutching his heart with what looks like a bloody hand. And when Munch was asked to imagine what was in the mind of the sorrowful man, he said, "I still feel the pain where my heart was bleeding because the threads of her hair could not be severed." And I show the picture of the separation not only to say as a symbol for social distancing, and we miss the connectedness with close friends and family. We just like to get hugged sometimes. But also to try to put a texture on something that's impossible, to get your arms around 100,000 deaths due to COVID-19. And perhaps we can't think of that number in a real sense, but we can maybe imagine one at a time, a man clutching his heart at the permanent separation, the permanent loss of someone he really lost in this particular infectious disease battle, COVID-19. Next slide. Go ahead for the next slide. So what I'd like to do is, especially for those who haven't been with the first 5 webinars, is recap some of the key findings and about what we've learned. From a large perspective, the key finding is our public health response lacked any robust preparedness for what I would call predictable recurrent pandemics. And I've gone over what I would call the ineluctable march of pandemics from HIV in the 80s to SARS in 2002 and 3, to H1N1 influenza in 2009 and 10, and then MERS in 2012, and now COVID. So these are predictable, and we never seem to learn anything and be truly prepared. And I hope we change as a result of this. And then, of course, the victims, many of them in pandemics, share the factors that they're often poor or elderly, like our people in nursing homes. Healthcare workers currently represented globally about 15% of victims. The disenfranchised who are in prison, for example, or in homeless shelters, a minority, and those who are densely crowded, either at home or at work, like the meat cutters in the Midwest. Well, we've learned about the virus, it is highly communicable with an R naught of 3. And for those of you who haven't been before, the R naught of 3 means that for every primary case, there are 3 more. And for each of those 3 more. So we go quickly from 1 to 3 to 9 to 27 to 81 exponentially. and it's 3 to 5 times deadlier than influenza. What's surprising is the vast spectrum of illness, from totally asymptomatic to a flu-like illness, which can be mild or severe, to clotting of arteries and veins due to some coagulation abnormalities set up by the sepsis. So the people present maybe with heart attacks or strokes because of clots in the heart or the brain. Loss of taste and smell, and up to 30%. And then late, just when you think we get over the virus, there's an immune overreaction in the course called cytokine storm. And that represents the chemicals that are inflammatory, but just as in a war where things are chaotic, it's as though our immune reaction caused us to be under friendly fire from the immune response. And then more recently, a vasculitis in children during convalescence, the so-called Kawasaki type syndrome, with children presenting with sudden heart failure, maybe 2 weeks after the onset of infection. And then what I think is poorly understood is the very prolonged convalescent period where people say 1, 2, 3 months later, they can barely cross the hallway. And the next big cap is the false dichotomies we've been facing early, and now we recognize it. Originally, is it either the health or the economy that has to be saved? And the truth is we need both. Central guidance or local, in fact. We need both. We need central guidance from CDC and local nuances. Focus on the general public versus high risk, such as those in nursing. Again, we need both. Next slide. What we know now, what works? The rapid institution of strict social distancing, and I'll show you some more data. Mask work, hand washing, disinfecting surfaces frequently touched. We still face a number of uncertainties, and we'll try to address these. The safe rate of reopening society, and includes our business, our schools, and the entertainment area. And at the arc of the pandemic this fall and winter, we don't know whether it's going to be steady or in fact come back with a large wave. And the availability of new therapies and vaccines. And while we have one new drug, remdesivir, it's not a home run. It's a good start, and it looks like it hastens recovery, but we don't know for sure that it prevents mortality, and vaccines will come back to. One of my concerns, and I consider it an immediate challenge, is what I'll call the unclear ability of a marginalized and soft-spoken CDC responding in the fall to a myriad of public health needs. This fall, we're going to have continued COVID-19. And whether it's going to be a flat surface or we're going to see a major wave is uncertain. Secondly, we're going to have the arrival on the crest of COVID-19, the annual influenza epidemic that actually kills 36,000 Americans a year. Now, there'll be clusters of childhood infection because the pediatricians are reporting in this country a 40 to 50% reduction in the acceptance of really proven vaccines. And then I think we'll have uncertain demands from natural disasters. This is supposed to be a rough year for hurricanes, but CDC will be asked to assist in the hurricane assistance or flooding or other kinds of natural disasters. And more recently, if you looked at Forbes magazine, there's an increase in ransomware, cyber attacks targeting hospitals. And these are hospitals, as you all know, that are being distracted just trying to control COVID-19. And CDC might be asked to lend assistance in those. So it's going to be very busy. And I think we really need a clarion call to respond to all of these. Next slide. So here are some data on international trends that are updated with the cases on the left graph and the confirmed deaths for very selected countries on the right. And if you look at the y-axis, I want to show you that these are in a log scale, going from 100 to 1 million. And then the days out from the first time that we had cases on the x-axis, going from 0 out over 100. So again, I would highlight what's in gray at the bottom, Australia, and I would put next to it New Zealand, who moved more than any other countries quickly and very solidly to limit introductions, social distancing, case finding, and contact tracing. They've done a good job, fewer than 10,000 cases. And Japan, a little bit higher, but still very good. And if you look at the blue line, China, they were slow to get going, but once they put in what some would think draconian measures, they were able to flatten that curve. And this, what when you have cumulative cases, what you want is a flat curve showing no more new cases. And again, a little higher, you see those countries in Western Europe, Italy, France, Spain, and to some extent Germany, that were a little slow and a little incomplete. And on the top, you see the US. We were slow, incomplete, and then finally, it looks like maybe we're leveling out. And I want to point out just below them, two countries, Russia and Brazil, that are moving up on the total number of confirmed cases very quickly, and Brazil behind us. Similarly, if you look at the right, the confirmed deaths, and again, on a log scale going up to 100,000. And again, it almost parallels those that got out early and they get out very solidly. And again, I want to point out towards the top, Brazil moving very quickly. And the latest I saw was 1,000 new deaths per day in our neighbor to the south. Next slide. Now, a very simple slide of the US cases, again, in log scale on the left, going from February 2020 to May 2020. And you can see we're finally, it looks like it's beginning to level off. We're at about 1.7 million cases. And it looks promising with this slide, but I'll come back. And if you look at the deaths, so it always lagged a couple of weeks behind. Again, going in a log scale from 1 to 100,000, we're right at about 100,000 now. But it doesn't tell the whole story. The US isn't responding in a same way in all 50 states. The next slide will show you what I'm getting at. Next slide. So you see a number of states here where the actual cases are rising, increasing. And you see Florida on the left top, Georgia, my own state of Virginia, continuing to climb. And the governor just said he's going to mandate mask wearing throughout the state beginning this Friday in any public areas. But Carolina to our south and over, including the Midwest with Wisconsin, Arkansas looked like they were going down and now they're rising very much. Oklahoma, North Dakota, Maine, West Virginia, again, rising after a fall. So what's important is the numbers are rising just as the same time that we're opening up society. And it raises concern that we're going to continue to see more cases and maybe not the flattening that we look like we were seeing initially if you look at the entire country. Next slide. So one of the measures I've said if you're following a pandemic is to look at the doubling time for reported cases or the doubling time for reported deaths. So if you look on the left-hand side, on the 1st of April, we had 200,000 reported cases. And on the 8th of April, 400,000 had doubled with a doubling time of 7 days. And you want that doubling time to expand if you're going to see any kind of control. By the 15th of April, 1.5 times went from 400 to 600,000. By the 1st of May, we had clearly doubled again, and we're at 1 million. And the doubling time appeared to be about 21 days, going in the right direction. And on the 14th of May, just 2 weeks ago, we had 1.4 million. If you look at the reported deaths on the right, on 1 April, 200,000 deaths, and on 4 April, 400,000. So our doubling time was 3 days. And you remember the Governor Cuomo saying this is what's happening in New York. Every 2 to 3 days, it's doubled. By the 15th of April, nationally, there were 30,000 deaths. So we were still on a 3-day doubling time, not making much headway. 1st of May, 60,000. So it looked like now the doubling time for deaths was 14 days. And if you look at today, 27, we're at 1.7 million, up, if you will, 300,000 from 2 weeks ago. And reported deaths to the right, we're now at 100,000, up almost 20,000 from just 2 weeks ago. So if you want to imagine, will we ever go to 2 million, for example, or will we go a doubling of our reported deaths, perhaps to 200,000? And I think that's certainly possible if we're not fortunate in responding to this in a strict way still. And we may see those numbers, 2 million and 200,000, by the fall time. So in about 3.5 months. Next slide. So I want to talk about respiratory droplets and particularly differences in size, the spectrum. And this beautiful illustration on the left shows a droplet of varying sizes encasing of the virus. What I'll tell you is, of course, over and over, that small droplets stay in the air for some time. The larger droplets tend to fall to the ground. And if you look at the upper right, we now know that sneezing, coughing, singing, and even talking in a loud voice, there are more droplets and even more small ones. So imagine being in an open bar after the second drink, the voices get a little louder. Keep that in mind. And the implication with all of this is with the use of effective masks, transmission will be limited. And I'll continue on the next slide. So this shows something that I think is important, that when people cough or sneeze or talk, there's a spectrum of respiratory droplet sizes. Heretofore, people talked about small ones and large ones. And what you see at the bottom is the size in microns. The micron is a millionth of a meter, going from 1 to, on the left, the very small one, tiny ones, all the way up to 500 microns on the right. And in different colors, I'll show the large, very large droplets that are 100 to 500 microns. These tend to fall quickly, 3 to 15 feet, but sometimes even 20 feet. So the 6-foot separation that CDC uses as a guide isn't absolute. Many studies show that droplets can go well beyond 6 feet to 20 feet. If you look all the way to the left, to the small droplets, the areas in blue, these are those that tend to be under 10 or even under 5 microns, and they stay airborne for 2 to 3 hours. And imagine that you're in a room you just walked into, but half an hour ago, someone who was coughing with coronavirus has now airborne particles that you saw on the previous slide, these microscopic hot air balloons that you can breathe in and then get infected. What's new is a recognition that, of course, there's a vast area in between, let's say, 10 and 100 microns that are what I'll call intermediate size. And what we're finding is those don't just fall to the ground. A portion of those are airborne for up to 14 minutes in one study. And so what I want to emphasize is two things. One, there's a spectrum of respiratory droplets, small, intermediate, and large. The large ones tend to fall to the ground. The very small ones stay airborne for hours, and those intermediate are still airborne 8 to 14 minutes later. This is an argument for the use of masks, I think, in public areas where the people are gathering. Next slide. So what about social distancing? And do we have data? Well, there are a couple of new studies that looked at reduced US daily COVID-19 growth rates. So the duration in days of social distancing is on the x-axis. And on the y-axis is the percent of reduction of daily COVID. So what you want is to be high on the curve. You want the maximum reduction. And this study examined 3,178 counties in the United States. And the study period was from 1 March, where they had 1 case in those counties, 27 April, over 900,000 cases. And there were 4 measures that the authors looked at: banning large gatherings, closing entertainment, restaurants, bars, music centers for concerts, closing public schools, and sheltering in place. And when they looked at the individual measure, those that had the most impact with the answers are closing entertainment and sheltering in place. Now keep this in mind as we begin the experiment of opening up our society, meaning opening up entertainment, getting away from sheltering in place. Now the graph, if you look on the left-hand side, looks at that the duration of days of all four of these measures whenever the counties decided to begin them, either early in the study period or late. So if you said, well, the county actually had 1 to 5 days of all four, well, you're over 5% reduction in daily COVID cases. That's good. However, if you were 6 to 10, you're closer approaching 7% reduction. And now you're further 11 to 15, you're over 8% daily reduction. And again, 16 to 20, where you want to be well above 9% daily reduction, impactful. So social distancing works. Next slide. In a very similar study, a different team looked again at individual counties in the United States. And what they showed is if you look at the time from March to May, and then on the y-axis, the cumulative number of deaths. And if you look at where we were on May 3rd, the end of their study, the number of reported deaths in those counties, 65,307. Then using the data from those same counties, they said, if they had actually begun to do this 1 week earlier, what would happen? And in fact, the total number of deaths would have fallen to 29,410, less than half of the total number actually. And then they asked another question. What if we had started all of these measured 2 weeks earlier? And again, the numbers would have been only 11,253 compared to the much higher 65,307. Again, we have lots of data accumulating. Social distancing works. Next slide. Next slide. So I've talked a little bit about the dynamics of various size droplets, some being intermediate, in fact, staying airborne, and some being very small, being in aerosols for hours. We now have some empirical data saying there's no question that some COVID-19 infections are actually aerosolized. And there are a number of point source infections with the first bullet without direct contact. So 16 of 32 choir members after a single practice where the choir members did not actually have direct contact came down quickly with COVID-19, strongly supporting an airborne transmission. 3 families dining at the same time at a restaurant, and they did not actually converse with each other, contact became infected. We also, if you now look, there are a number of benign COVID types. There are 4 in the United States that routinely cause about 20% of our colds and up to 10% or more of community pneumonias. And those, in studies of the RNA of those in the air was found, suggesting that the virus was there even before COVID-19 in other types of more benign COVID types. Some of these are named like OC43 and 229E and others. We now look back, and some SARS patients were super spreaders. And for some reason, they were able to infect not only 1 or 2 people or 3 in the nearby area, but 10 or 20 or up to 50. The only way to explain that is airborne. And we now know that normal speech generates some intermediate and small droplets. So the data are now accumulating for airborne. And since the R0 is about 3, probably most COVID-19 infections are spread by larger droplets, but we don't know if the number is 5% or maybe as high as 20% of COVID are super spreader related, meaning they're spread by aerosols. Next slide. So again, the value of masks. There are a number of reviews recently that are on the slide. Cotton masks are better than no masks for blocking influenza droplets that are intermediate in size, greater than 5 microns, or the very small, less than 5 microns, seasonal coronavirus when studied in infected adults earlier. Second, surgical masks are more effective in general than homemade masks in blocking bacterial counts of volunteers. Their filtering capacity was about 89% with surgical masks versus a range of 49 to 86% with homemade masks. COVID-19 patients are most infectious early when they're totally absent symptoms or very mild symptoms. And that's an argument for wearing masks at all times, even when people look very healthy. They could be pre-symptomatic or totally asymptomatic. One study in China showed healthcare workers in 3 hospitals who wore masks and other things contributed had no infections versus 10 or more among those hospitals where they didn't wear a mask routinely. COVID-19 patient on a flight from China to Toronto wore a mask, and when the passengers were all checked, there were no transmissions. And the models estimate the fall in R1, which is similar to R0. R1 doesn't take into account that you have to be susceptible. It just says of all people, after a single case, 2.4 people picked up infections. And models estimate that number could fall from 2.4 to 1.35 if 50% of people use masks with only a 50% efficacy. So I think we're getting more and more data. The value of masks for preventing infection and maybe serious infection and death is strong. Next slide. So now the whole area of opening up colleges has become really controversial, and there's a lot we don't know, and I want to highlight a lot. So first of all, there were 2 articles since in April. There was one in the New York Times by Christina Paxton, who is the president of Brown, and then more recently by Corey Robin, who's the president of City University in New York, CUNY, in the New Yorker in May. So what Christina Paxton said, we have to open up our colleges because the financial threat is catastrophic. She went on to say higher ed actually contributes significantly $600 billion to the gross domestic product. And she sees what we need is testing, tracing of contacts, and separating the students, perhaps by renting hotel rooms for quarantine, isolation, using digital technology for tracing contacts. Very shortly after that, Corey Robin wrote a very strong rebuttal and saying, look, we're talking about the geography of class in America. Only 16% of undergraduates, he said, in the United States live on campus. His students, the CUNY students, are often poor. Their university system doesn't have wealthy donors seeking tax deduction. They can't afford testing, hotel costs, and the public spending for public universities is really important. He sees it as a bequest of permanence from one generation to the next. And then in a strong rebuke, in the final sentence is this: sending students, professors, and workers back to campus amid an epidemic simply because they need cash is a statement of bankruptcy more profound than any balance sheet tally. So this tells you a little bit about the sociology of colleges in the United States and the debate. More recently, in the next slide, I want to tell you in the next slide that closing universities has varying responses. California's state system a couple of weeks ago said their 500,000 students will definitely not open for in-person teaching. They're taking a very cautious approach and saying, we're not ready. We don't know how to keep social distancing. In contrast, Notre Dame said they're going to open their school. They're going to open it on 10 August. There'll be no breaks, no fall break. They're going to work until Thanksgiving directly. They need testing, masking, social distancing as needed, so they didn't define the details. And their goal, of course, is to limit travel to and from campus and thereby limiting inadvertent introduction. So a couple of different approaches. Now, just today, and posted on online last night on the next slide, the president of Notre Dame, Father John Jenkins, wrote this op-ed, which you can read today in the New York Times, reopening Notre Dame. He argues it's a moral, not a scientific decision. And what he said is, look, one of our best scientists in the United States, Tony Fauci, is a Notre Dame grad, but this really isn't a scientific decision. And what he relies on, it's a moral decision. And he says, our decision to open up is based on three principles: health of the academic society. And he said, if that were the only this principle, he said, we close until we had a vaccine. The second principle, he said, is education in mind, body, spirit requires residential life and personal interactions. And third, we need to advance human understanding by way of research, scholarship, and creative expression. And the only way we can do this is continue to use their principles and continue to teach. Then he went on to define a healthy society. And he said, like going to war, a healthy society is willing to take risks. And you may not like that analogy, but I'll come back to that in a second. And then actually alluding to Aristotle, he said, courage defined by Aristotle was a mean, an average, if you will, or a balance between a rashness and a heedless of danger on one hand and timidity that paralyzes it on the other. And if you look up Aristotle's comment on courage, he often uses the most courageous people were those in battle who found the balance despite being in danger. They were not timid in response. So we have another sort of reflection on this very difficult decision ahead and this kind of a new experiment, if you will. And we can talk about the morality, which has to be a part of the decision, but to base it entirely, as Dr. Father Jenkins does, is quite interesting. Next slide. I don't think any university will find testing for infection at universities so simple. So many universities said, we'll screen everybody as soon as they arrive on campus. They may do it once, or maybe they'll do it repeatedly. So let me go walk through the example. Assume there's a low 1%, it could be 5, but I think it's only 1% prevalence of asymptomatic infection in this asymptomatic population of college students. And let's say we have an ideal test to look for infection in these people with a 99% sensitivity, meaning if you have 100 tested positive, 100 people infected rather, you'll have a test positive 99%. And 99% specificity. So if you have 100 people with no infection, the test will say 99 had no infection. Doesn't get much better. So if you look to the bottom right, 1,000 college students will say, and if only 1% had infection, and you could argue it might be a little more, it won't change the numbers, there would be 10 under the infection group total. So with 1,000 total, 10 infected, 990 are in the middle, no infection. So of the 10 infected, the test 99% sensitive would pick up all 10. They would all test positive. Of the 990 with no infection, 99% would be picked up, or 980, but there still would be 10 who would test positive. Now, if you look at the total test positive, it's 20 people. However, only 10 have true infection, 10 have no infection. So with a low prevalence of this, it shows you the not so simple answers you get. All 20 would have to be quarantined. They would be followed, of course, for symptoms, and then any contacts would have to be followed. And if you said to a university, they're only going to do this once, I would say, that borders on maybe useless to find that information. I would prefer, and it's going to be expensive, you're going to do it every 2 weeks. Still have to grapple with the fact that for the most part, in the first 6 months at least, if not the whole year, you're going to have 50%, half of the people with false positives. Testing isn't simple. Next slide. So I want to emphasize the fact that COVID-19 is a global threat. As a result, we need global leadership, global cooperation, and global investment, not only for the current control, because what happens in another country affects all of us, but also for eventual drug and vaccine distribution. We have to make sure that it gets throughout the world. This summer, we may see travelers from southern hemispheres who are getting away from their cold weather and want to come to our warm weather, and some of them may be introducing new infections. And the flattening of curves in Europe may in fact rise this fall, coincident with not only opening society, but opening up travel. The current threat described as catastrophic spread in Brazil. If you look to the right under there, it says 310,000 confirmed, but their own modelers in Brazil and Sao Paulo and Rio have estimated there in fact may have 3.6 million cases. And with a young population, many of the people infected, including those in hospitals, are 20 to 40-year-olds. So if you look at what are options from trying to limit introduction from all over the world, not just talking Brazil, from Europe and South America, from Asia. Well, we could do temperature screening of all travelers, preferably at source. Well, the optics are good, it's cheap, but we'll not only miss over half of all COVID carriers and who are infected, but we'll also have false positives, people who have temperature elevation for some other reason. We could do nothing, and that doesn't feel comfortable. Or we could do rapid virus screen of all travelers. To me, that would be the most effective, but obviously one of the more expensive approaches. And I don't think we have a plan yet. I think the country has decided to cut travel from Brazil. We don't know how tightly that will be and whether there'll be any openings in that. Next slide. Now, the pathway to a COVID-19 vaccine is shown on here because we're still waiting to see some of the data. And one of the first things that happens is you take a prospective vaccine, you do animal testing, preclinical testing, and what you're looking for in the 4 bullets at the top, any signal for harm, any toxicity in those animals given the vaccine. And when do those animals develop an immune response, hopefully with antibodies as a marker of the immune response? And or do those antibodies actually neutralize the virus in a test tube? You can have antibodies, but they may not neutralize the virus. There are antibodies to hepatitis C, but that's used as a marker of infection. They don't neutralize the virus. Third, vaccinated animals, are they protected from a viral challenge after they've received the vaccine? And do the controls then get infected? And then lastly, any sign of an unusual but possible immune-enhanced deleterious reaction to infection. And what that means is there are some vaccines when we tested, such as respiratory syncytial virus, that were when those people who got the vaccine, those children, when they actually ran into the wild strains in the community, they had a worse disease than those who had not had prior vaccination. It's a very unusual immunity-enhanced reaction. Now, the clinical tests are usually divided into phases 1, 2, and 3, where small numbers of tens to hundreds to thousands to test safety in a larger groups, increasingly robust immune reaction, and are they protective, as in phase 3. Now, lately, the Oxford vaccine's been getting a lot of press, and it's a recombinant adenovirus vector. And what that means is that people are being injected with a live virus, adenovirus, that is presumed to be harmless, and I think it is. But that adenovirus's genetic material has been altered to include genes that encode the spike protein of SARS-CoV-2. So what happens is the adenovirus gets in, doesn't cause us any problem. Our body starts making the spike protein. And as it does, the body's immune system says, this is foreign, I've never seen it before. We need to develop antibodies to it and hopefully protect us. So the Oxford vaccine has been tested in mice, shown all the safety preclinical tests I've shown you above, then in rhesus macaques, primates, and now is in phase 1. There are a number of other recombinant vaccines. There are actually messenger RNA vaccines. And if you go back to biology 101, you remember that in the nucleus there's DNA and RNA. And then as we start to get ready to manufacture proteins that help the virus to live, the nucleus actually makes this messenger RNA a single strand and then push it into the cytoplasm, which are where the sites for the protein production for that particular cell or for the virus will actually be made in the cytoplasm, the factories that make the new protein. Some vaccines look very, very good in messenger RNA in preliminary animal studies. There are some companies making inactivated virus, meaning they take the virus, they kill it with something. It doesn't cause any harm directly because it's dead, but the body sees the pieces on the outside that it doesn't remember, makes antibodies to those, and we get a good vaccine, such as we have for flu. And then there are nanoparticles. These are very tiny, if you will, particles that encase the spike protein. And these are then released into the body. The body makes antibodies. These are in phase 1 or phase 1 and 2. Next slide. So on the horizon, what do we see? Well, new clusters of COVID-19 are likely as we open up. Some of them may not be very impressive until the fall, which I think is where we'll see more imported cases. And as the warm season closes, more indoor activity, and especially as schools and colleges and universities open. I'm concerned about the timidity from CDC and the need to ramp up for the fall. All of the challenges they will see, COVID-19, the arrival of influenza, the natural disasters in the clusters of childhood infection, the cyber attacks that I mentioned earlier on the healthcare system and the medical system. And they need to tell us about testing and the protective equipment, contact tracing, and update us frequently, and they haven't done that. There are some people advocating that there are businesses that do not mandate masks, and maybe what you could do is have separate hours for mask users or non-mask users. And the way they roll that out is mandate separate time intervals for those who like to wear masks, maybe 8 to 10 in the morning, or those who do not in grocery stores, hardware stores, athletic fitness centers would maybe then 10 to noon. But I ask you, now that you know about intermediate sized particles or those aerosols that are very small, would you want to come into that grocery store or fitness center an hour later and maybe take a risk of inhaling those droplets? I'm concerned about the growth of the anti-vaccine groups. I think we need to listen to their concerns, and some of them, rather than just ignore it or try to tell them in very bland language, we know we have a vaccine that works, it'll protect you. Address them, respond on social media for a balance of both emotive and rational advice. The anti-vax groups have much more postings on social media than those people like me who support vaccines. And they're often very emotive, like your children could be in danger. The schools could be undergoing great harm. Next slide. So I close with this slide, again, trying to put texture on and meaning to the number 100,000 deaths. It is so hard to grasp what that means. But if we start to think about them as who they are, individuals, such as former warriors who are now veterans of foreign wars, who are in our nursing homes, or the first responders who died, the policemen, firemen, nurses in emergency room, or the meat packers who got infected, and some may have died as a direct result, who prepared the meat for us that we take for granted. And I'll just read this poem from John Donne 400 years ago. No man is an island entire of himself. Each is a part of the main. Each man's death diminishes me. Ask not for whom the bell tolls, it tolls for thee. Sean, thank you very much. Went a little bit over time, but I'll be happy to answer questions for whenever we need.
Thank you, sir. And we have a number of questions, so let's get to them. Abby says thank you, and I think on behalf of all of us, thank you very, very much. This is tremendously helpful, and there's about 100 of us in the room, so let's get to it. Colby is the first question. A number of folks want to know the answer, and the question is, as communicators, many of us are trying to plan activity for the second half of 2020, including events for the fall. With mixed data available, some communities are opening back up. How, Dr. Wenzel, would you approach planning a gathering in the fall of 2020? Is it best simply to avoid it, or will there be safe ways to gather in groups of 25, 50, or 100 or more if we're using masks?
Yeah, I think the safest approach, I've been asked by a country club, can they open up their dining room? Schools, of course, what can they do to open up? Families that want to get together, and it's understandable, of course. If you want to begin, I would begin outdoors. And I would say, look, if you can meet outside and you want to observe some distance, preferably outdoors, maybe at least 10 or 15 feet apart, and you each want to bring your own meals or your own adult beverage or lemonade, I think that would be very relatively safe. The real question comes about indoor activities. Several reasons. One is air handling is something that we really haven't talked about. Engineers say they can do some things. And if you're talking about indoors on a plane, for example, is it a closed atmosphere where there's a minimum exchange with fresh air? So there's air handling, again, the problem. And again, knowing that you're going to have some people who are asymptomatic, who are just talking, and you can have intermediate size and very tiny droplets. Then you have to sort of ask yourself, what comfort do you have in dealing with it? Perhaps you have family members that you haven't seen for 3 weeks. They haven't left out their house except to go to the grocery store, nor have you left your house to go to the grocery store. You have thereby minimized the risk, I think. Nothing will go down to zero, but you've minimized it, and particularly if you have a small number. So if you're talking about getting 5 to 10 together, that's one thing. If you're talking about 50 or 100 or more people getting together inside in a closed environment where nobody's wearing a mask, I think you increase the odds of transmission. So there's sort of some of the boundaries, I would say, that you have to think about.
Our friend Lishka asks, a very specific question. What kind of mask would you recommend for going to the grocery store? If you're going grocery shopping, what kind of mask? Is it a bandana? I've seen a lot of my neighbors walking around with just bandanas tied around their heads when they're walking through the neighborhood. Or do you need an N95, or what would you recommend?
Yeah, I think it's going to be very hard to get N95 masks, but many of them are still in need at hospitals throughout the country. And there's some cities you've seen, for example, like Montgomery, Alabama, where there are no ICU beds today. They're so busy. So I would say any kind of surgical mask you can get, or any mask that meets similar kinds of tightness, at least around. So masks, again, you would love to see everybody wear them if you're going to a grocery store, because the people who are wearing them who are infected are really protecting you. And it's almost a moral argument for them. Not wearing them actually influences your health, even though you're doing the right thing trying to protect them. So there are some people that go to another extreme. I have some friends that correctly, I think, in a hospital say you should wear a mask plus a face shield. And some of them are now saying, maybe a face shield is a better way to go than a mask if you're going to the grocery store. Or some are using both. At least wear a mask is where I really would fall down on that. Any mask, I don't think a bandana is as good as a mask. If that's all you have, then please wear it.
Friend Catherine asks, what do you think about bringing office workers back into the offices sooner rather than later? When do you think this might be safe? And should everybody be wearing masks if they're in an office setting?
Well, again, we know that social distancing works. We know that masks work. We know that we have maybe 20 states where the rates of infection are actually rising while opening up. So I would be cautious about bringing everybody back to work, particularly if many companies have learned that they're going to actually have more proportion of their work home base from now on. I think they've learned that it's been productive and it works. And then the kind of question is, what sort of social distancing do you have at work? Will everybody wear a mask? Will there be several stations within just a few steps where you can get the antiseptic for hand washing? Will there be disinfecting of surfaces touched? Um, are the air going from one office to another just in the linear direction, for example, that so there could be a super spreader? You'd like not to have that. You'd like to have some barriers, just the opposite of the way many offices are set up today. So again, a lot of it comes down to what are you prepared to do? Will you be adding any testing of your employees? If so, how often? Knowing that maybe you might have up to 5% who at the most might be positive, and so you're going to have many false positives. So these are all part of the things that I would say, what level of risk, what level of background protection will you offer your people who want to be comfortable returning to work, just as the business at the top wants to maximize their income.
Next question comes from our friend Katie, who asks, when a vaccine is approved here in the United States, should we be concerned at all about the long-term side effects and or the company that's producing the vaccine?
Well, I'm not sure what the second part means, but if you mean long-term consequences of any vaccination, sure. We have vaccines all the time. Most of them do extremely well. The long-term consequences could be with coronaviruses, as in MERS and SARS, maybe the loss of antibody, excuse me, the loss of antibodies over 2, 3, 4 year period. If you meant maybe there's some sort of contamination, not sure, it depends on the vaccine. I think that's a much lower risk.
Okay. So what I meant by just to follow up there. So what that means is it might be likely like trying to think of what a good example is. Well, like the flu vaccine, you need to go get a shot every single year. You need to get a booster for certain things like tetanus every few years.
Yeah, well, that's why I mentioned, Sean, it wouldn't be surprising to see with coronavirus, this one, too, a decline in antibody over time. And what that would mean is maybe every 2 or 3 or 4 years, you might need a booster.
Gotcha.
So that's very possible. We're only going to know that by following people. And there'll be what some people would call a phase 4 after all the trials. Let's see how people do with a widespread use with the first million people to get the vaccine, to look at very rare side effects on the one hand, but also what happens to antibodies over a period of time.
Lishka has another question. She says, for places like the University of Notre Dame, what is your sense of why these leaders can't think a year or two down the road or in advance? This is not forever. Can't we make a plan for online learning for a year or a year and a half? Maybe there's some socioeconomic implications here. But what if large, wealthy universities like this provided students with laptops and Wi-Fi for a year? Academia won't benefit from students getting sick and dying. And I'd add on to that, before we came on, one of the things that Tristan noted was the community in which Notre Dame is located, South Bend, Indiana. We all know from the mayor of South Bend who ran for president recently, Pete Buttigieg, that is a community that's struggling a lot economically across all kinds of cultural identities. It is a town that would seem to fit a lot of the demographics where we've seen large spreads of coronavirus.
Well, it's a tough question. I think what Father Jenkins would say, I'm guessing, and probably need to have him answer, is that we thought about this as an ethical issue. And hopefully he means a balance of maintaining health, which he stated, and trying to actually give students the academic experience. Now, having said that, it turns out that, he cited Aristotle. And in fact, Plato was Aristotle's teacher. And the word academy comes from Plato. And what he did is actually bring his people to what the Greeks would call academia. And that's a sort of a park on the edge of Athens where he'd bring them together for the Socratic, very intense challenge of their strongly held principles. And I think Father Jenkins would actually say, this is what we try to do at Notre Dame. Now, is he prepared for a problem with health in any of his students? Would he be able to answer the question, does he have in mind right now the number of infections that would cause him to rethink this, the number of hospitalization of Notre Dame students, or you'd hope never would happen, a death or more in a student at Notre Dame? Very unlikely. But are there any numbers of infection and hospital stays that would cause him to reconsider that? If you said, well, why didn't he look down the road 2 years? I can't answer that question, of course. I think they probably did. And then this is their moral argument, much more based on morality than I think health, but he would argue that they're arguing both.
Okay, my colleague from across the park, Derek, asks, almost every day I go out for a run or to bike on local walking trails. As I pass by people, many typically pull their masks up as I go by. Are they actually protecting themselves or me in that moment? I got to confess, I do this too. When I go for a run, I bring a mask, but I really only kind of put it up when I'm near other people. Am I doing it good there?
Excuse me. I think the risk when you're outdoors, having a 5 or 10 second passing of another runner or biker is extremely low. And if you said, well, they want to get it from 99 down to a 99.9% to put the mask on, okay, I think that may be true. There's probably a very marginal improvement by putting the mask on to protect themselves, and more importantly, probably to protect you. I would thank them as I was running by, because they're really thinking about you, not themselves. In reality, at least by the science, they're thinking of you. Thank them.
I will do that. And I will continue to put it up even if it's having a bare effect. But I guess the big lesson should be, let's get out and run, get some exercise. That's the more health benefits of doing that than sitting inside.
Yeah.
Okay. Catherine asks, this is also a really good question. I've been wondering about this. This is about cross-contamination. Is it safe to pull your mask on under your chin and then up over your face again? That's exactly what I do when I run. I have it around my neck. I pull it up when I go by something and I put it back down because it's uncomfortable.
Well, it's probably a good idea if you can, and it's not easy to do. Put the mask on with your hand, tightening the top part around your nose so it fits snugly, and then don't touch it, because I don't know where your hands have touched. The outside of the mask potentially could be contaminated from someone else's nearby cough, which person didn't have a mask on, for example. You don't even want to contaminate your glove, because that might mean you might touch your eye inadvertently and still expose yourself. So try not to do that. If you have to, and it happens, particularly if you're exercising and put a mask on, which for the most time you probably don't need that if you're outdoors, because most people are running alone. I hope, anyway.
Yeah, I keep trying to I got my wife out with me yesterday, but for the most part, I've been alone. Kathy asks, we'll make this our final question because I know we're over the top of the hour and I want to be respectful of your time. Kathy asks, I've had several friends who've recovered from COVID, and that's good news, Kathy. Is it safe for her to see them? In other words, do we know if they're immune now that they've recovered from a COVID-19 diagnosis?
Well, there's a lot we don't know, but in general, based on what happened in MERS and SARS, those people who had clinically positive disease and then were found to have antibodies, they're not infectious, and they are almost surely immune. Given the uncertainties, of course, you might have to qualify that a little bit, but based on experience with other pandemic coronaviruses, they should be immune and not infectious.
Gotcha. And I think with that, oh, wait a minute. Michelle has a question. Let's make this our final. Could Dr. Wenzel discuss the impact on public spaces such as libraries in a future session? I'm really curious to hear more about this given their value to communities, but obviously the potential risk indoors. Well, so I guess maybe the thing I should say is we'll save that for the next one. And maybe what I should ask you is, could we have a next one? Would you mind coming back and joining us in a couple weeks' time?
No, if your people don't wear out and it's still valuable, I'd love to contribute.
I think by virtue of the number of folks we had with us today, it's very, very helpful. I'm grateful our friends from Brazil were with us, and people are saying Dr. W is the best. Thank you. So yes, if you don't mind too terribly, we will take responsibility for working with you. Everybody, for now, be well. Thank you, Dr. Wenzel. If you can see the chat, Dr. Wenzel, lots of thank yous. And for all our friends down in Brazil, please do be safe. Hopefully this was helpful to you and to everybody else out there. Wear a mask when you go out. Wash your hands frequently. Go get some exercise. And be kind to yourselves. I think that's going to be a really, really important thing. This is not going to be over tomorrow or next week, which is why we keep doing this. So hang in there, be brave, and we'll all get through this, I promise. Sir, with that, thank you so much. For you, please do be well. Thank you to your family for letting us borrow you for so much time. Super, super grateful. And we will see everyone soon. And a recording of this, for the person who asked, yes, will be up online. Yabby usually turns these things around fairly shortly. So we will share that with you and everybody. Give us, sometime in the next 24 hours or so. All right. Thanks, everybody. Be
Thanks,
well.
Sean.
Thank you,
Thanks,
sir.
Kristen.